Well, thank you for the opportunity. Carol has asked me to review some of the basics, and I understand that this will be very much a review for some of you, but I think it's important that we all are singing from the same page of the hymn book, basically. And so if this is a review, it's a review, but I just want to be sure we're all together on this. Now, I have no disclosures, and these are the objectives that we had previously listed for this presentation. I want to start with the review of the fact that vitamin D exists in two chemically distinct forms. They're called ergo and cholecalciferol, respectively, or D2 and D3. D3 is the natural form that we find in animals, and it's the form that we make in the skin on exposure to ultraviolet B light. And so I'm going to be talking about D3, but occasionally people will be wondering, well, what about D2? And so here I've just, dealt with it. Serum 25-hydroxy-D is the way vitamin D status is evaluated. The lower end of that acceptable range, as several of the speakers have already hinted, is 100 nanomoles per liter or 40 nanograms per milliliter. Now, the canonical scheme for vitamin D is that the D is made in the skin. It's 25-hydroxylated in the liver. It's subsequently hydroxylated at the one position in the kidney, and that product circulates in the bloodstream and goes to the intestine, where it stimulates the formation of the proteins that are important for the active transport of calcium from our food into our bloodstream. This is basically what we've known for 20 or 30 or maybe even 40 years now. That's why I refer to it as the canonical scheme. That's what, if you are going to school, you learn in the basics. And as I've already indicated, 25D is the functional indicator of vitamin D status, and it's a principal storage form of the vitamin. You can see that on one of the posters outside, where we've tried to quantify how much of the vitamin D activity in our body is in what forms and where it's located. Now, we've come to understand that that the canonical scheme is not adequate. We need to work with an expanded scheme. The top one is the one that I just showed you a moment ago. It's the endocrine side of the story, and it's 125D circulating in the blood as a hormone going to the intestine to produce a specific effect, as is true for all hormones in the body. But the bottom side is where all the excitement has been the last few years. That's the autocrine side, and what that means is that these products are made internally within a tissue and act locally rather than circulating through the bloodstream. Furthermore, they don't have the kind of feedback controls that you would take for granted with the endocrine side. So we do some 1-alpha hydroxylation in the periphery as well as in the kidney. Now, that's right within the tissues concerned in response to cell-specific signals that will vary from tissue to tissue. Now, the problem that we've associated with vitamin D all these years is rickets or osteomalacia, and that's on the endocrine side of the story. And I'm going to review some of that for you because it's important not to neglect the calcium part of this important hormone. Inadequate concentrations of these minerals, calcium and phosphorus, that are necessary to form bone are behind the problem of rickets and osteomalacia. And furthermore, in the process of the body trying to do something about this, it mistakenly lowers the serum phosphorus level, and that impairs the function of the cells that are responsible for building bone. It's not just that there isn't mineral, but the cells that are responsible for doing it are themselves impaired because they are sick from not having enough phosphorus available to them. This is the type of thing that we used to see a lot of with rickets, bowing of the legs. Here are a couple of other examples, more recent. And you can see the reason for that. The bones are actually bent. They're deformed under the circumstances. Much more serious kinds of deformities occur as well, but I do want to call your attention to the fact that in 2008, just 2 years ago, the American Academy of Pediatrics actually doubled the vitamin D intake recommendation for children. And what I'm sharing with you today is the results from a paper that was just published this month in the journal Pediatrics. That noted that fewer than 1 in 7 children in the first year of life were given any vitamin D at all. And those who were formula fed did best, not because formula is better than breast milk, but because formula contains some vitamin D. and depending upon the age of the child, from 20 to 37% met the AAP recommendations. Breastfed babies, 5 to 13%, mixed-fed, 9 to 14%. In brief, the vast majority are simply not getting what it is we're talking about. Now, in this particular study, which was based on the infant feeding practices study, 43% were breastfed at least early on, 26% formula fed, 32%. And here is the performance. Look at this. This is the formula fed babies. Here is the target, 100% receiving the AAP recommendation. The breastfed and the mixed fed are just way down in the basement, as you can see. It's just absolutely horrible story. And as I say, published this month, the message is not getting out to the practitioner. This is really a very modest recommendation, actually. It's adequate for the first year of life, but it's not adequate after that. As people grow, they get bigger bodies and they need more. This is a contemporary report this month. Now, we used to think that we didn't have to deal very much, but this is a report from Japan just a year and a half ago showing craniotabes, these bumps on the forehead of this little 5-month-old these are some of the stigmata of Rickets. Fortunately, this will go away when you provide adequate vitamin D supplementation, but we're dealing with problems that are present here today. And that's, this is an example of a pelvis that's been severely distorted by vitamin D deficiency. It's highly likely that a woman, if she'd been pregnant, could not deliver a baby through that. And of course, that would have been one of the factors that led to the paling of the skin as humans moved north out of Africa into Europe, because very rapidly, those who couldn't have babies would not have been able to reproduce. Now, to go back to what's behind all this, it all starts with insufficient calcium absorption. That would tend to lower the concentration of calcium in the extracellular fluid or blood of the body, and that stimulates the parathyroid glands to produce parathyroid hormone, and that then ultimately leads to an increased synthesis of the hormone that's responsible for the active absorption of calcium, and that should then improve that. The problem is, with vitamin D deficiency, you can't do that. And so the whole system hangs up right there. Now, that leads to further falls in the calcium concentration, further rises in parathyroid hormone, and that leads to a further lowering of the renal phosphorus threshold. That lowers the serum phosphorus, which the bones need, and that leads to what's called a calcium times phosphorus product in the bloodstream that's too low to support mineralization. And that's where the problem comes in. If we don't have that, then you can't mineralize the bones and they become deformed as the child grows. And growth itself is stunted because of the damage that the low serum phosphorus causes to the growth apparatus itself. So that's what's behind all of that. So let me look a little bit more at calcium absorption in detail with you. Now, these are complicated slides, but they're important to pay attention to. What I have on this axis is net absorption of calcium as a function of calcium intake on this axis. And all these lines here are derived from actual data. This is active absorption presented as a fraction of the total calcium intake. That's active, that means it's vitamin D mediated. It's what gets across as a result of vitamin D stimulating the formation apparatus. And I'm going to work you through this a little bit here. This would be a typical active absorption fraction, about 16%. Now you see here that at 16% and an intake of, say, 1,400 milligrams per day, you are absorbing slightly more than 200 milligrams of calcium per day from a big intake. That's 1,700, 200 getting absorbed. And if you have a lower intake, say 800, you're not absorbing anywhere near as much. The importance of that 200 milligram line is that's what the average adult needs today in order to offset losses from skin and excreta. So if we're not absorbing 200 milligrams per day, we're tearing down our skeleton in order to get the calcium that we need. And this kind of a nomogram, if you will, allows us to do that sort of calculation. Now, here we are with a typical intake. The recommended intake for individuals over age 50 today is 1,200 milligrams per day, and you see that just hits the 200 milligram per day line. Now, what happens when vitamin D status deteriorates? The active absorption line drops. So now you'd have to have 1,400 in order to meet that need. And if it drops still further, you might need 1,800. Until finally, in severe vitamin D deficiency, you'd need, say, 3,000 milligrams of calcium per day in order to get the amount that is required under those circumstances. Realistically, nobody's going to get 3,000 milligrams per day. So you see, there is this strong interdependence. And the bottom line is that in the absence of adequate vitamin D, you cannot absorb enough calcium for health. And so that's why you tear down your skeleton. But equally, all the vitamin D in the world won't help if you don't have enough calcium in your diet as well. So these two actors are playing together in this story. And it's extremely important that we keep both of them in mind. I mean, if you don't have much calcium, even 100% absorption is not adequate, because 100% of not very much is not very much. I mean, it's just that simple. Now, what we haven't realized until recently is that vitamin D does not cause calcium absorption. I need to stress that. Vitamin D does not cause calcium absorption. It enables calcium absorption. It enables the body to regulate calcium absorption. It doesn't cause it per se. It's 1,25-dihydroxy vitamin D, which is controlled by the body. That's what elicits expression of the calcium transport apparatus in the intestinal lining cell. But we've only just recently realized that you have to have both molecules, both 25-hydroxy-D and 1,25-D, must be present for the enterocyte to absorb calcium adequately. And the evidence for that is that we do not see hyperabsorption in outdoor summer workers, despite the fact that they have high blood levels of 25-D. It doesn't cause calcium absorption. And similarly, in patients with nutritional rickets or osteomalacia, we don't see absorption of calcium at all, despite often high levels of what we think is the responsible hormone. It's 1,25-D. The problem is you have to have both of these hormones. You got to have 1,25-D and 25-D present for the enterocyte to do its job. And if you don't have one, it's not going to work. If you don't have the other, it's not going to work. So we need both. And that's why keeping an adequate blood level of 25-hydroxy-D is important, not just for all of the other effects which we're going to be talking about the rest of the day, but it's important also for the calcium side of the story as well. Now, how much is adequate in terms of absorption? Here are some data, probably the only data in the world that'll look seriously at the relationship between serum 25-D and calcium absorption fraction. And you see here that we've got two sets of studies, this one from my laboratory, this one from another group. And you see that absorption fraction rises as vitamin D status improves. And doesn't take a lot of imagination to see that there's kind of a threshold effect there. Now, it would be logical to think, well, hey, you just said that this doesn't cause calcium absorption, but it sure looks like it's causing calcium absorption there. But what's happening is that when you give vitamin D to people who are calcium deficient, then they do improve calcium absorption. But if they have plenty of calcium, then they don't. And that's shown by the fact here that the body is perfectly able to up and down regulate calcium absorption once you give it plenty of vitamin D. So it can go way down to low levels, it can go way up. It tries to regulate down here as well, but it doesn't have as much room. So think about vitamin D as an enabler. It's what the body needs to do whatever the specific job is. We'll see a dozen examples of that through the day as we go from tissue to tissue to tissue. Vitamin D isn't causing any of the effects. It's simply enabling the body to deal with whatever the current stresses are. It's a part of the apparatus the body has to have in order to do that. Now, I'll spend some time going through that mechanism this afternoon. Now, I want to go through some of the studies that would back that up. For instance, In a study we published several years ago, we raised serum 25-hydroxy-D from 50 nanomoles to about 80 nanomoles per liter, and we measured calcium absorption under the circumstances, and this is what we found. That absorption fraction went from about 22% up to around 37% simply by raising the vitamin D status from 50 to about 80 nanomoles per liter. That was a very substantial improvement in calcium absorption. Now, the reason why we originally published 80 nanomoles as the level that was needed to enable calcium absorption fully was that's where it seemed to plateau for us. Now, for other effects, we're going to find plateaus at different levels. So there's nothing magical about 80. It just seems to be that's where it is. If we step through this a little bit, there's the calcium absorption effect, but we measured other components of this process. The serum calcium went up as well, as you can see here. This is all within the normal range, and a physician would never notice this because it would come back in the normal column from the path lab. So you wouldn't pay attention to that. But it's a physiological effect, and it's doing exactly what you would expect it to do. And similarly, the parathyroid hormone level dropped as well. So that all the pieces of the puzzle were acting just precisely as the model said it should. Not all of my experiments turn out that neatly, but this one did. Similarly, Heike Bischoff, in a study of the data from NHANES, the National Health Nutrition Examination Survey, which has been ongoing now for 40+ years, sees this kind of an effect for bone mineral density as a function of serum 25-hydroxy-D level in the population. The top line being for non-Hispanic whites, the middle line being for Mexican Americans, and the bottom line being for Hispanics. And you see bone mineral density, at least in the non-Hispanic whites, never does plateau. I mean, up here as high as 150 nanomoles per liter looks to be a better situation than down here even at 80 or 100. And to a substantial extent, that's true. Nobody would want to be below 80 nanomoles per liter by these kinds of standards because there is a disadvantage to being down there. This is an important study published several years ago in the British Medical Journal, a 5-year randomized trial of vitamin D supplementation in healthy British adults, raising serum 25D from 53 to about 75 nanomoles per liter. Not where we would like it to be, but that's what the study did. And even that was sufficient to lower the risk of osteoporotic fracture, hip, forearm, and spine by 33%. Hard data, level 1 evidence, randomized controlled trial. Now, that's not the only set of data of that sort. This is a series of such trials with anti-fracture efficacy as the endpoint. And it shows an important point that the level of 25-hydroxy-D we can achieve in the patient is important in determining the results. If we give such a low dose that we don't achieve much of a level, we don't get an effect, hardly surprising. But it takes levels above 100 in order to be certain that you're absolutely getting an effect there. So here's another piece of evidence pointing to a level of 100 as being as low as you would want to go. There are questions of safety that I was asked to address. This is a batch of 33 men, average age 39, who were dosed at a rate of 5,000 to 10,000 international units per day, every day, from October through February. And this is what happened to serum calcium. There was, the serum calcium, if anything, fell a little bit over this period of time. There was not a single instance of hypercalcemia. This happens to be beginning and end, but we followed the serum calcium every month, and there was no rise above the upper limit of normal. So again, that's one indication of safety. So in our experience, doses of 5 to 10,000 for 4 to 5 months do not elevate serum calcium, do not elevate the urine calcium. And furthermore, it's important to understand that those kinds of doses produce levels that are frequently found at the end of summer in outdoor workers. And in those outdoor workers, as I've stressed, we do not see hyperabsorption of calcium. Now, here's one such example. This is what we got at the end of summer in a batch of outdoor summer workers with values up above 200 nanomoles per liter. But notice there's a huge amount of variability from person to person. Some people do not get up even to a healthy level at the end of summer in Omaha, Nebraska. And it's a fairly sunny part of the world. But everybody falls, and by the end of February, you're down, the average is below 80 nanomoles, and there are very few people above 100. So there's a need for supplementation, you see, under these circumstances. These are the same individuals, of course. Now, I want to refer to a brief paper on toxicity that was published now just 3 years ago. This is a log scale here, so we're starting at 1,000 international units per day going up to 10 million. I'm not recommending this, please understand that. And this is serum 25-hydroxy-D. These red circles are the means of 15 studies of controlled vitamin D supplementation in which we were working out the pharmacology of this potent compound. And the triangles here are 8 studies that reported individual cases of toxicity. I'm highlighting them in orange so you can pay attention to them. Now, the important point is these are people with toxicity, but notice the doses that are required here. There is no toxicity below 500 nanomoles per liter or 200 nanograms per milliliter, and no toxicity in reported cases at intakes below 30,000 international units per day. It'd be a rare individual that might need 30,000, 1 in a million, I don't know. It's not what the everyday person kind of needs, but it's important to know that there is safety in this range here. Kidney stones are a problem that keep cropping up, and the reason for that, I think, is that people tend to think, well, vitamin D causes calcium absorption, and if you absorb more calcium, you're going to have to put it out in the urine, and that'll cause kidney stones. And I've tried to stress to you that isn't true. Vitamin D doesn't cause calcium absorption. It enables the body's regulation of calcium absorption. And I'm going to show you some data. These were reported recently from the Women's Health Initiative. This was the kidney stone risk per 100,000 population, and it was over 300 individuals per 100,000 population per year. And in the placebo group in that same trial, there was a slightly lower risk. And this got a lot of publicity, and that led people to worry about whether there was kidney stone risk. Now, on this scale, I put a number of other studies, and I want to show those to you. But I want to stress that the stones in WHI were self-reported. It was not a pre-planned outcome variable, and the outcomes were never adjudicated. We don't know. Nobody looked at the record. Nobody got the medical record to see what really happened. So we don't know. And the vitamin D dose achieved was only 200 international units per day. Now, if that is causing kidney stones, then I ask you. I pulled together in this publication, I pulled together all of the published calcium trials. And I looked at the reported kidney stone risk in those calcium trials. You know, just giving older women calcium to see what would happen to their bones, basically. And you see, the placebo group in all these trials had, if anything, a slightly higher kidney stone risk than the calcium people, but essentially the same number. So there is no role of calcium there. And when we look at the epidemiological data from Olmsted County, Minnesota, and from the Nurses Health Study, we're looking at relatively low stone risk, below 100 per 100,000 patients per year. Now, what was going on in WHI, nobody knows, but I think you have to, I mean, any experienced epidemiologist would say there's something wrong with these numbers. In brief, WHI stone numbers are so far out of line with all the other stone data available in the US that they can't be accepted as real. And nor could they plausibly be attributed to the tiny dose of vitamin D that was achieved in WHI. Now, I do want to show you where we stand right now. This is a frequency distribution for serum 25-hydroxy-Ds in a semi-rural population in eastern Nebraska, and it's nearly 1,200 women, as you see here. Fits a Gaussian curve very, very nicely, as a matter of fact. That's the mean there, and here we see this level of 80 nanomoles, which is where calcium absorption gets optimized, and here's where 100 nanomoles would be. And if you just even take 80, you've got 65% of this population getting moderate sun exposure, having inadequate vitamin D levels. And if we were to use a standard of 100, it would be much worse. This publication from the journal Pediatrics just last fall shows exactly the same phenomenon, but these are for children, non-Hispanic whites, non-Hispanic blacks, and Mexican Americans. These values in the peach colored are below the lower end of the reference range for NHANES, and those in white are below 30 nanograms per milliliter. Not 40, but below 30. Look, 98% of black teenage girls below a minimally acceptable level in the United States today. Not all that much better for Mexican Americans or for Caucasians. The younger children tend to do better, but still 40% is totally unacceptable. I just have to sum up by saying that all studies in virtually all nations, irrespective of latitude, show that the majority of the world's population has an inadequate vitamin D status. And so to wrap up, vitamin D deficiency is a worldwide problem, all ages and races, and alarmingly, rickets, classical rickets, is on the rise today. It's a totally preventable problem. Never should be allowed. Prevention and treatment are inexpensive and easily implemented. Serum 25D needs to be above 40 nanograms, as is commonly found in people who are outdoors a lot. The needed total vitamin D inputs, I think, can be succinctly summarized as 75 units per kilo per day. That applies to all ages and all body sizes, so that covers the problem of obesity as well. And with that, I thank you.